Now, I don't know how many men here already have prostate cancer, and I'm wondering, for those who do, when you're diagnosed with prostate cancer, would you like to have a low testosterone level or a high testosterone level? Can I see a show of hands for low? Okay. How about high? More say low. Okay. Now, if you look at the relationship between testosterone and prostate cancer, which we're going to do first, then we're going to talk some about anti-androgenic cocktail, and then I'm going to show you the results of triple hormone blockade with a more than a 5-year follow-up on 130 men. So this author points out in 1996 that there is no doubt that established prostate cancer is stimulated by testosterone. And we would all agree with that? Yes? No. No? One person doesn't agree with it. Okay. And as I always say, everyone is entitled to their own wrong opinion, including myself. Now, Dr. Schroeder was certain of this, and I think if you take men with metastatic hormone refractory prostate cancer and you treat them with testosterone, almost everyone will get worse. Well, this year at the American Urologic Association, they reported on 5 patients who all had radical prostatectomies for prostate cancer, of course, but they all had low testosterone levels on their own. So they were treated with testosterone, and all of them had marked improvement in clinical symptoms, increased testosterone, and as of 6 months follow-up, none had a rise in PSA. So here you have some urologists who are actually giving men with prostate cancer testosterone. Must be crazy. And the reason that they're considered, it has been considered crazy, is if you look at the package insert on any preparation of testosterone. By the way, it would be nice if everyone turned off their cell phones and pagers and just put them on vibrate. I would very much appreciate it. So if you look at the package insert on any preparation of testosterone, what you'll find it says is testosterone is contraindicated for anyone with prostate cancer. What does that mean? If you have a strep throat and you want to be treated, what's indicated is penicillin. Penicillin is indicated to treat strep throat. Now, if something is contraindicated, it's the exact wrong thing to do. You cannot do it. And it says that on all testosterone preparations. The reason it says that is primarily from a number of articles which we'll review. And the 2 authors, Fowler and Willett Whitmore, are the ones whose articles made the most impression. And these articles were published in 1981, 1982. They looked at 67 men who were treated between 1949 and 1967 with testosterone when they had metastatic prostate cancer. In the group, 34 of them were relapsing. Their bone pain was worsening in spite of castration and estrogen. 4 of them had previously been untreated, but again, metastatic prostate cancer. 14 had no symptoms. They were in remission from their castration and estrogen therapy. And the example they give, which is probably most terrifying, is of a 63-year-old male. He's had prostate cancer for 8 years. He's failed castration. He's failed estrogen. He's admitted to the hospital with severe generalized incapacitating bone pain. They treat him with testosterone for 2 days, and he becomes paraplegic, paralyzed below the waist. And that will put the fear of God in any of us. Then they talk about, in the same article, another patient who's 67. He's had castration for metastatic prostate cancer with bone pain, and he had only a 10-month remission. Now, if you only have a 10-month remission, it means you've got super aggressive disease, because we know the average remission is at least twice that. So then they give him estrogen, and it only helps for 1 month. So this is a guy who's not going to do well on any form of hormone blockade. They put him on testosterone, and on the 3rd day he becomes disoriented, lethargic, hard to arouse, and dies on the 4th day. And they say his death was from testosterone. Now, what are the side effects of estrogen? The most common side effect? Blood clots. Heart attack, stroke, phlebitis. This man had been on estrogen, and he's at bed rest in a hospital. I think he died of estrogen therapy. Prostate cancer, who do you know becomes, if they're dying of prostate cancer, suddenly becomes disoriented, lethargic, and dies the next day? That's not a prostate cancer death. Well, these authors mentioned 3 other patients who died, but they don't say anything about them. But these 2 articles are why everyone believes testosterone is contraindicated for men with prostate cancer. But you know, if you look at certain experiments in cell cultures and in rodents, you find that testosterone can inhibit the growth of certain types of prostate cancer in certain experimental situations. In fact, there's a cell line, LNCAP, stands for a lymph node from someone with cancer of the prostate. And this is a cell line that grows in cell cultures, and it has a very interesting response when you add testosterone to the cell culture. Testosterone can either stimulate prostate cancer cells to grow, and sometimes it inhibits prostate cancer cell from growing. That's intriguing, isn't it? And what happens is if you give low doses of testosterone, if you put in the cell culture, you stimulate prostate cancer to grow. But if you give high doses, you actually inhibit the growth of prostate cancer. And they found 3 different factors, growth factors, that actually inhibit the growth of prostate cancer when testosterone is administered. This is basic fibroblast growth factor, interleukin-6, transforming growth factor beta. And you know what? They're all anti-angiogenic. So prostate cancer cells are stimulated in high doses, with high doses of testosterone, they're stimulated to make these 3 anti-angiogenic substances which inhibit the growth of prostate cancer. Low doses stimulate prostate cancer up to a certain level. Then when you give higher doses, there's a prostate cancer growth arrest. And that is what is called a bell-shaped curve. The effect of testosterone on this prostate cancer cell line, the level of the testosterone given determines whether you stimulate it or inhibit prostate cancer growth. And what's fascinating is benign prostate cells don't have this characteristic. Only prostate cancer cells. And transforming growth factor beta, which is one of the substances that testosterone stimulates, has clear-cut anti-angiogenic properties. And this is not new information. This is reported in a textbook from 2001. And we know that till something gets in a textbook, it's been around for quite a while. Now, what about side effects? You're talking about giving testosterone, let's say to someone who doesn't have prostate cancer or someone who does. Well, you might worry that you're going to cause prostate cancer. Turns out, if a man doesn't have prostate cancer, giving him testosterone does not increase his risk of getting prostate cancer. But urologists are very reluctant to give testosterone to men that are going through andropause, that are hypogonadal. There is a concern that it could cause or worsen sleep apnea. That isn't yet well studied. Now, men have higher blood counts than women. The reason for it is testosterone. If a man goes on hormone blockade, one of the side effects of hormone blockade is anemia. And the reason a man gets anemic is because his testosterone level is brought down to a castrate range. So if you give too much testosterone to a man, could you cause too high a blood count? And if you have too high a blood count, could that increase the risk of of getting headaches, feeling like a full head, or even causing blood clots? Well, you just check the blood count. Don't let it get so high. And can it increase the risk of benign prostate hypertrophy? Well, that's strange, because when is the risk of benign prostate hypertrophy, BPH, greatest? As a man is between 55 and 75? What's happening to his level of testosterone as he ages? Goes down. So as the level of testosterone goes down, the risk of BPH goes up. Now, what are the side effects of not having enough testosterone, or when you're on hormone blockade? Discouragement, depression, irritability, anxiousness, nervous tension, lack of vitality, fatigue or burnout. How many women have suffered, as their men suffered from these side effects, how many women can testify, yes, these are some of the side effects that hormone blockade causes? Well, what happens if you give men testosterone? You get the reverse of all these. What are some of the other symptoms of hormone blockade? Joint and muscle aches, sweating, hot flushes, increased need for sleep, weakness. And there's a concept of an improved overall sense of well-being. On hormone blockade, you have just the opposite. Then there's also the problem with gaining weight on hormone blockade, and it tends to occur around the belly. There's increased risk of cardiovascular disease. There's actually increased insulin resistance, which worsens diabetes. This is when you're on hormone blockade. These two are reversed. The arrow should be up, and this should be up. When you don't have testosterone, there's worsening of diabetes, and there's an increased risk of Alzheimer's. If you take testosterone replacement therapy, there's improved control of diabetes and a decreased risk of Alzheimer's. So these two are correct with testosterone replacement therapy. And this particular author gave moderate doses of testosterone to some patients, to some men, no history of prostate cancer, and he found that the cholesterol level goes down by 9%, the HDL-LDL ratio stays the same, and the triglyceride level dropped by 20%. And these improvements were maintained through the 12 months of study, but disappeared when you stopped testosterone. What happened to the PSA in these men? With moderate doses of testosterone, PSA declined by 30%. Isn't that interesting? This author, well back in 1989, you remember the first question I asked, would you like to have a low testosterone or a high testosterone when you present with prostate cancer? He looked at a series of prognostic factors, and he found that if men present with metastatic prostate cancer to the bones, 110 men, average age 68, if their testosterone was less than 300, the average time of remission lasted only 14 months. If their testosterone was higher than 300, the average remission lasted 31 months, more than twice as long. And at 24 months, after 2 years, only 24% of men with low testosterone were in remission, and 57% of men with high testosterone and presentation were in remission. So I'll ask again, if you have prostate cancer, how many would like to have a low testosterone? How many would like to have a high testosterone? Okay. So low pretreatment testosterone is not only an independent risk factor for metastatic disease, but it also predicts for extraprostatic disease if you have surgery. And patients who present with high Gleason scores have lower testosterone levels than men who present with lower grade Gleason scores. And what's interesting is if these men have a radical prostatectomy, the level of testosterone goes up. It's as if the prostate cancer for men with high Gleason scores suppresses testosterone. And if a man presents with a low testosterone level, first of all, he's more likely to have prostate cancer if you did a screening population. Second of all, he'll have more extensive prostate cancer, and he'll have a higher risk of a Gleason score 8 or higher. The question of testosterone stimulating prostate cancer in someone without known prostate cancer, this is why urologists I mentioned are afraid to prescribe it. As of 1999, there were a total of 8 cases reported. And surely if you gave 10,000 men a piece of bazooka bubble gum, at least 8 of them over the next several years would come up with prostate cancer, and you wouldn't blame it on the bazooka bubble gum. But this is what has held urologists back. We're going to go back and let's look in some detail now at the article that said that testosterone is contraindicated, or that has been interpreted, because they don't say it's contraindicated in the article. They say you should use extreme caution. But it's been interpreted as don't ever do it. Well, I said they had 52 patients evaluable. They actually had 55 patients. But they decided that 3 of them they weren't going to count because they didn't have an unfavorable response in the first 7 days. That's kind of cheating, isn't it? Because the guy who died on the 4th day, they counted him. They didn't give a 7-day break to him. And this is about my favorite slide of the evening. The duration of treatment required to evoke a recognizable unfavorable response was in some cases greater than the duration of treatment when there was no unfavorable response. In other words, the guys are on testosterone, there's no unfavorable response. So they stop testosterone, then there's an unfavorable response, and they say, aha, you had an unfavorable response to testosterone. And they were counted as unfavorable. The unfavorable response didn't occur till they stopped testosterone. But these are some of the failures. And in the same study, there were 7 patients treated with testosterone for an average of 5 months who said, I feel great. And one of them was on for 420 days. But these patients were in the 18 who either were untreated or were in remission at the time testosterone was started. So the 34 with advanced disease that were progressing after castration and estrogen, only one of them did okay. Those patients, obviously, you should virtually never treat. But of the 18 men who weren't progressing, 7 of the 8 improved with testosterone. 7 of the 18. So the same authors that everyone quotes as saying you shouldn't give it said the response of patients with metastatic prostate cancer to testosterone has not been evaluated symptomatically in a large number of patients. That's in 1967. And they noted the paradoxical ability of testosterone to induce symptomatically beneficial responses. But everyone quotes this article as saying you should never give it. And they also mention in the article they're not the only ones who found that testosterone can help some men with prostate cancer. There are also other authors that have. But in that article, they did a review of literature. And they said, we've looked at the medical literature, and we found 138 men who have been reported by other authors, and 128 of the 138 had an unfavorable response when they got testosterone. Now, 125 of them were in relapse, but some of the authors that they reference are Brendler, Prout, Morales. And so I decided I'm going to look at those old articles and confirm for myself how unfavorable the responses were. So Brendler was one of the authors, and he had 3 patients with advanced prostate cancer, metastatic, for whom the prognosis was regarded as hopeless. That sounds pretty bad. So they chose them for the first study. 2 of the 3 got much better with testosterone within 2 weeks. One of them had a palpable, they could feel on digital rectal, the prostate got smaller. And these are reported as unfavorable. Not by the authors, but by the guys Fowler and Whitmore. One man was treated with a testosterone pellet. His improvement lasted 5 months. His symptoms recurred, so they gave him another shot of testosterone in a pellet. He again improved. The 3rd patient got worse for the first week, but then returned to pre-treatment levels. Yet Fowler reported 2 out of 2 unfavorable. One of the authors that they said had unfavorable results, his conclusion was testosterone alone may therefore be indicated in cases of relapsing metastatic prostate cancer which are unresponsive to estrogen. And they give an example. This Morales is one quoted that doesn't, that the first authors say had unfavorable responses. They had a 52-year-old man. He had severe low back pain. Biopsy showed prostate cancer. He had locally advanced disease on digital rectal, widespread bone metastases, skull, spine, both arms, both legs. He had been castrated. Then he had estrogen for 3 months. His low back pain came back, requiring narcotics. So they admitted him to the hospital, Morales, and they put him on a protocol where they give testosterone daily for about 10 days. And at the end of 10 days, they believe you revved up the metastases, you've turned them on, and you give the man intravenous P32, radioactive phosphorus. And the radioactive phosphorus will then hone in on the metastases and try to kill him. So for the first 4 days, when he just got testosterone, he had severe exacerbation of bone pain. So Fowler and Whitmore would say, here's an example where testosterone made the guy worse. On the 5th day, his pain abruptly disappeared. He never got radioactive phosphorus, and in fact, they treated him with oral testosterone. He was pain-free for 9 months, and his prostate cancer blood tests, which had been elevated, normalized. This is in the era before PSA. They measured PAP, prostatic acid phosphatase. And this was reported out in 1971. Another example that was called unfavorable, not by the authors, 72-year-old, bilateral castration, orchiectomy, estrogen for 2 years, severe bone pain, extensive bone metastases, treated him with testosterone for 3 weeks, gave him radioactive phosphorus, and his pain's gone. Was it the testosterone or the phosphorus, or both? So then they restarted his estrogen. Guess what? Bone pain came back. So they stopped the estrogen, they gave him testosterone. He remained pain-free until death. One of the other authors that is quoted by the Fowler and Whitmore as saying it's unfavorable, reported 10 patients, most of whom experienced an increased sense of well-being and some decrease in pain. And none of them got blockage of the urinary tract. This is the most incredible example. And this is a reference that's shown as how testosterone doesn't work. Guy is 76, he's admitted to the hospital with severe back pain, weakness, loss of appetite, only weighs 89 pounds. He'd had orchiectomy and estrogen. He was unable to sit without assistance. He appeared terminal. He had the extensive bone metastases, and he had enlarged lymph glands in his groin. His prostatic acid phosphatase, which is like a PSA, 50 times normal. And he was put on a double-blinded study. He got shots 3 times a week. He didn't know what it was. The doctors didn't know what it was. 1 month later, he was pain-free. He had an excellent appetite. He was walking without assistance. He went from 89 pounds to 112 pounds. His prostate cancer blood test improved 75%. Later, he gained 30 pounds. His response lasted 321 days. And when they looked to see what they had treated him with, what this miracle drug was, it was testosterone. So that's certainly, these are references that I only came upon in preparing for, I gave a lecture yesterday in Boston. I had the honor of being a keynote speaker at a symposium that was in part sponsored by Mass General, and virtually all the other doctor speakers were from Harvard, which is where I did my fellowship. And I showed some of these slides. I showed most of them, actually. And I had the nicest response from these doctors, one of whom is Phil Kantoff, who's the editor of Prostate Journal. And he actually said he agrees with me. When I lectured there 6 years ago on triple blockade, he thought I was a lunatic and dangerous. This visit, he was impressed with triple blockade and admitted he's using it. And he congratulated me on the testosterone. So this was a patient who in 1966 was 66 years old, PSA 7, Gleason 10, a couple months of hormone blockade, radiation therapy. By August 97, his PSA was 27. And he got hormone blockade. PSA went to 0, but only 8 months later, his PSA rose back and is now 67, and his testosterone was only 200. I gave him chemotherapy and the hormone blockade. He was off treatment for 13 months. He had enlarged lymph glands in his abdomen, the largest 2.7 centimeters. I gave him chemotherapy until January 02, December 01. He stopped chemotherapy, and his PSA had dropped to 1.64, rose briefly to 1.71. But his chemotherapy ended in December. He's still on just hormone blockade. And I put him on prostate cancer anti-angiogenic cocktail, which is a cocktail of medicines I've come up with. And his PSA from February 02 to April 02 dropped quite a bit, by more than 2/3, even though chemotherapy could never get his PSA down this low. I then put him on testosterone replacement therapy, May 9th, 02. That's more than a year ago. And this is his testosterone, 1800. Normal is 300 to 1100. Testosterone 1800 in May 03, his PSA 0.217. As his testosterone has gone up, looks like his PSA has behaved itself. And in fact, last Friday, his PSA was 0.172. This man feels phenomenal. 1800 PSA, testosterone, 0.172 PSA. He's still on the anti-angiogenic cocktail, no hormone blockade, and high-dose testosterone. This is a patient, unfortunately, the slides didn't work out, the graphs, but he was 75 in December 96, PSA 8, Gleason 8. A bone scan showed metastasis, but the radiation therapist apparently didn't realize it, which is being polite. And he gave him radiation therapy, and at the end of radiation therapy, his PSA was 9. A few months later, it was 17. His bone scan showed new metastases. I gave him hormone blockade. His scan improved, but his testosterone never recovered. It stayed about 100. In December 01, I put him on testosterone. In August 02, with a testosterone of about 400 and a PSA about 0.17, I told him to double his testosterone dose. His testosterones now run over 1,000, and his PSAs are 0.1. He sent this most wonderful handwritten note to me a few months ago. Thank you, thank you, thank you. He was absolutely ecstatic. He had had his first orgasm in 8 years. Really nice. And this is looking at his September through 02 through May 03. He's been on testosterone replacement therapy since December 01. He has metastatic prostate cancer. He's failed radiation. And these are his PSAs, 0.104. And it had been 0.14 in February. Testosterone 1551. This is a gentleman, actually my hairdresser's father. Gleason 7. Had a PSA of 6, radical prostatectomy, and it had spread to a lymph node. Metastatic prostate cancer. His urologist treated him with Lupron and 1-Casodex for 16 months, and that ended in September 02. He came to see me, and I said, you know, he was feeling terrible and depressed and weak. I said, stop your testosterone, your hormone blockade. He did. And I said, you know, we could give you testosterone. I explained all the risks and benefits and whatnot. And he goes on testosterone in September 02 with his own testosterone that was only 39. I gave him testosterone replacement therapy, and went up to 948, PSA 0.006. His testosterone is now 1900, PSA 0.003. And he's been on testosterone for 8 months. Another guy with metastatic prostate cancer to a lymph node, had chemotherapy and hormone blockade. He went off treatment. His testosterone wouldn't get higher than 300. Gave him high-dose testosterone replacement therapy. His testosterone 1262. Now his PSA 0.69, but this guy still has a prostate gland. And testosterone will stimulate your normal prostate gland cell to make PSA. So I'm hoping, none of this is from prostate cancer, and how many guys with a prostate would trade his position here to have a testosterone over 1200 and a PSA 0.69? It doesn't get better than this. One of my favorite patients had a radical, had radiation, had chemotherapy, hormone blockade, then more chemotherapy, and on his second round of chemotherapy, December 01, his PSA is rising. He's a fireman, he doesn't look well. I stopped his chemotherapy here and put him on prostate cancer anti-angiogenic cocktail. His PSA drops to 0.06 in May 02. Similar story, give him high dose testosterone, 1600, PSA 0.5. So he's been on testosterone over a year. He has this cute way of explaining when before he was on testosterone, he tried to work out in the garage with his weights, and he would say he could hardly lift anything. He said he went on testosterone, he goes in the garage, and now it's like this. It's very impressive. And his wife has been extraordinarily grateful. You're on your own in figuring that out. This is a physician who was 59 when he had a radical back in 89. He took 2 months of hormone blockade. He came to see me when his PSA 10 years later was 11.99. He didn't want to go on hormone blockade. He had a young wife. So he took thalidomide, Proscar, and Iridia. And May 99 to June 02, PSA does fine. But his testosterone is only 200. So I put him on testosterone replacement therapy. This scared him. He went off testosterone. Turned out he had a kidney stone with pus behind in his ureter, behind the stone. So he's back on testosterone replacement therapy. His testosterone 1600, his PSA 12.9 May 03. And when he came to me, November 99, testosterone 200, PSA 12. And 4 years later, PSA 12.9, testosterone 1600. That's not a bad 4 years. And to show that even more mature gentlemen may feel better on testosterone, in 1989, that's 14 years ago, he was 72, so he's 86. And he had a radical, he later had hormone blockade, but every time I'd see him through last year, how you doing? Terrible. I don't feel so good. So we talked about different things. He went on testosterone, and when his testosterone got up here, how you feeling? Wonderful, wonderful. So he went from feeling terrible to feeling wonderful, and his PSA is 1. Back in 98, it was 2.36. And without a prostate, all of this is coming from cancer. Another example, this guy's giving me permission. He was the original Spider-Man, the stunt man. He'd never, his face was never shown, but he was the guy in the costume in the TV series. And he started on testosterone in June 02. He still has a prostate gland. A year later with testosterone 1500, PSA 1. And back when he presented for hormone blockade, his PSA was 7, testosterone 308. So 3.5 years later, testosterone 1500, PSA 1. His only treatment was triple hormone blockade for a year and high-dose testosterone. This is the patient who's been on testosterone the longest in my practice. In 92, he was 58, he had a Gleason 7, he had locally advanced disease, PSA was only 5. He took Lupron and flutamide initially for 1 year, and then had a repeat prostate biopsy. That was a repeat biopsy, and his biopsy showed persistent prostate cancer. And he took Lupron and flutamide for another year, and he had a repeat biopsy, and that showed a Gleason 7. And he took it again for a year, and he had a Gleason 7 in 5 out of 6 cores. So after 3 years of hormone blockade, not my type, he still had persistent prostate cancer. So he stayed on hormone blockade for a total of 7 years, total 7, and his PSA had been unmeasurable for 6.5 years, and he came to see me in July '99. And I said, well, you can go off hormone blockade, but your testosterone's never going to recover. You've had 7 years of hormone blockade, the testicles are dead. So he stopped anyway, and he thought about it and went on testosterone replacement therapy. And he still has a prostate gland. He likes the feeling with higher dose testosterone, and he has a PSA of 3.24, but it was 3.29 in January, and it's been as high as 4.57. And in this particular case, his testosterone had gone up and his PSA had gone down. In this case, he had a high testosterone, lowered his testosterone, PSA went up. This is a gentleman who started with a PSA 95. He had hormone blockade. He had only 18 months off hormone blockade. He was seeing Dr. Eric Small in San Francisco. He put him back on hormone blockade, which ended in July 2000. And I wanted to come up with something so he wouldn't have to go back on hormone blockade again. So I treated him with a prostate cancer anti-androgenic cocktail, and later added in high-dose testosterone. So in July '02, PSA 10.5, and in May '03, 9.67, testosterone 1260. Now this guy only had 18 months off hormone blockade the first time. And on intermittent blockade, every time you're treated, the next cycle off is shorter time off than the first time because you're more hormone resistant. This guy has been off hormone blockade just about 3 years. First time only 18 months. So we've altered the natural history of his disease with cocktail and high-dose testosterone. Now, the authors that I previously quoted, who were, we were told by the first guys, Fowler and Whitmore, that their articles showed that testosterone is bad for you. This is their conclusion, their own authors and their own authors' words. Obviously, the experience reported here is at some variance with the opinions expressed by other investigators. That's 1967. We conclude that the effects of testosterone on patients with advanced prostate cancer, whether previously untreated or not, is neither clear-cut nor predictable in many instances. And it appears to us, it's another author, it appears to us that if continued progress is to be made in the treatment of prostate cancer, the exact role of testosterone in the induction of cancer and the maintenance of it must be ascertained. Check out the date that this was written. 1950. 53 years ago, the author said, you know what, we're not quite sure what testosterone does for men with prostate cancer. And I'll say, still not sure, are you? 1957, another author, 2 cases of obvious responses to testosterone. He concludes, the mechanism of response to testosterone in these 2 patients is obscure. These observations invite the development of new concepts to explain the response of prostate cancer to testosterone. New concepts. What has happened in the last 46 years with new concepts? They don't exist. So what are my conclusions about hormone blockade, testosterone, and prostate cancer? Hormone blockade results in remissions in most men with previously untreated prostate cancer. For men with metastatic prostate cancer, continuous blockade virtually always leads to hormone-resistant and hormone-refractory prostate cancer after an interval of only 18 to 20 months. If testosterone was always harmful for men with prostate cancer, why doesn't every man who has a radical prostatectomy or radiation therapy get castrated? If testosterone is always harmful, castrate them. And why does the risk of prostate cancer go up as you age, but your level of testosterone goes down? And if you're on intermittent hormone blockade, your testosterone levels usually recover to pre-treatment levels 3 to 6 months after hormone blockade is stopped. If testosterone is always harmful for men with prostate cancer, why aren't these guys on intermittent blockade dead? And if your own testosterone is 300 to 500, is that better or worse than a testosterone of 1,000? The answer is, of course, nobody knows. No one has studied it. So what do we know for sure? Testosterone is contraindicated for men with prostate cancer. It says it on the package insert. Testosterone could hasten death and or lead to irreversible toxicities, including paralysis. That's what the authors Fowler and Whitmore have shown us. And I cannot overemphasize enough that this is the message you have to take home from tonight. You can't go out, call your urologist and say, give me testosterone. Because if you're in the group that, for whom testosterone is dangerous, you could die or get paralyzed. Having said that, it's obvious that testosterone can induce favorable responses in some men with prostate cancer. We need to develop a method that predicts who will benefit and who will be harmed. Since these same conclusions were made in 1950 and 1957 in the articles I quoted, if you remember Louis from Casablanca, the police guy, I'm shocked. And they were told him there's gambling going on in the back room, and then they came up to him with his winning. I'm shocked that there's gambling. I'm shocked that the research hasn't been done. And I'm disappointed that this critically important area of research has been totally ignored for the past 50 plus years. And I'm reminded of, from Dr. Saul Rosenberg, was a professor, an oncologist at Stanford University, who was an expert in Hodgkin's disease and non-Hodgkin's lymphoma. And I always thought that would be pretty boring to super subspecialize. But he pointed out in a lecture, pick one disease, study it well, and it will carry you to the ends of the earth. And of course, he wasn't just talking about geography if you get invited to lecture in different cities. He was talking that you could really learn a great deal about one disease if you just concentrate in it. And one of the Nobel Prize winners in medicine said discovery consists of seeing what everybody has seen and thinking what nobody has thought. Now, Huggins and Hodges in 1941, University of Chicago, I might add, my son went there, to the graduate school, the undergraduate. Huggins and Hodges in 1941 won the Nobel Prize in Medicine for showing that if you castrate men with metastatic prostate cancer, a good percentage go into remission. Turns out it was not nearly as high as 90 or 95%, but a good percentage went into remission. And think of the arrogance that we've shared tonight to say, you know what, you're right, you did deserve the Nobel Prize for that. But you know what, it isn't correct for all men with prostate cancer. There are major exceptions, and we need to figure out who the exceptions are. And the significant problems we face today cannot be solved at the same level of thinking we were at when the problem was first recognized. And Albert Einstein said that. I hope that my presentation today will help stimulate our quest to discover the true relationships between testosterone and prostate cancer. It seems that the more I learn about prostate cancer, the less sure I am of what I used to know about prostate cancer. Okay, I've made reference to an anti-angiogenic cocktail. I kind of have to rush through these slides because I want to get to triple blockade. Thalidomide, GM-CSF, interferon, interleukin-2, I'll go over some of this. Zometa, Proscar, Celebrex, anticoagulation, very, very mini dose oral chemotherapy, and possibly calcitriol. And the goal for a man with metastatic prostate cancer, you can't cure him. What you have to do is induce tumor dormancy. Just control the disease. The new paradigm for treating any form of metastatic prostate cancer should be just to induce tumor dormancy. And what we're doing is we're attacking the blood supply. We're not attacking cancer cells. Capillaries are lined by a single cell, endothelial cell. And that's going to be our target of anti-angiogenesis therapy. And this is kind of a nice little cartoon here. And what it shows, thalidomide is one of the agents we talked about that's anti-angiogenic. And the tumor cells, in this case multiple myeloma cells, are producing certain growth factors that stimulate new growth factors to make more cancer cells. And thalidomide blocks the action of those growth factors. And showing it this way, you have cancer cells that are producing growth factors, and the growth factors then attract endothelial cells to start then by binding by receptors, and it starts making a little outpouching to grow towards the cells. The endothelial cells then begin to migrate towards the cancer cells, and they do this in response to certain pro-angiogenic factors, and ultimately they bring blood supply to cancer cells. Cancer cells cannot grow larger than 2 millimeters without blood supply. Well, this is brand new information. Endostatin is actually 600 million years old. That's million without an S. It's found in worms, but not found in sponges. And in an article back in 1993 in the New England Journal of Medicine, it was reported that some 39% of women had breast cancer at autopsy, not 30%, but only 11% of women develop breast cancer in their lifetime. And for prostate cancer, 80% of men in their 80s have prostate cancer. Only 7% have a symptom of it in their lifetime, and only 3% actually die from it. So could breast cancer cells or prostate cancer cells be producing anti-angiogenic factors that help prevent the primary from growing or the metastases from growing? And in fact, Dr. Folkman, the father of angiogenesis, reported that when you remove a tumor, think prostate, by surgery or radiation therapy, that often results in vascularization and growth of dormant metastases. So if somebody's prostate cancer cells left the prostate before their radical or their radiation therapy or their seeds, if you remove the prostate, you can stimulate the metastases to grow. And this is part of the reason why I never recommend any form of local therapy for prostate cancer. Certain tumors produce enzymes that activate angiogenesis inhibitors. They inhibit the growth of their own metastases, and they can also help to, it's actually found like angiostatin, endostatin, anti-angiogenic, antithrombin 3, which in turn can prevent the growth of remote tumors, not just metastases, other cancers. Like in someone with prostate cancer getting lung cancer, the prostate can help prevent the development of other cancers with these anti-angiogenic factors. And this is referenced from October 2002. I don't know how much you know about Down syndrome, but Down's patients almost never get prostate cancer. In fact, for all cancers in general, they have only about 1/10% the amount of cancer that others get. The only exceptions to that is this is supposed to be CML, chronic myelogenous leukemia. This is one of the slides we were working on 15 minutes before the lecture started. Chronic myelogenous leukemia, and testicular cancer. Those are the only malignancies that Down's patients have in high percentage. And what has been found is you look at Down's patients, they have 1/3 more endostatin than normal controls. And Folkman believes that it's this endostatin, higher levels of endostatin, that help prevent all other cancers in Down's patients, with the exception of chronic myelogenous leukemia, which has to do with an extra chromosome that's abnormal in Down's patients. And testicular cancer. Like, why should they have more high incidence of testicular cancer? Turns out testicular cancer makes its own unique endostatin and endostatin receptors. I think that's just fascinating. And these are a couple of quick slides that you can see. Thalidomide is probably one of our most effective anti-angiogenic agents. This was a guy, PSA 1.9. He goes on thalidomide, and a year later 8 months later, his PSA is half that. And same kind of a thing. This went down in 1 month. Another one, thalidomide, PSA goes down. He had some side effects, went up, restarted, went down. Again, a quick response. All of our responses to thalidomide have occurred within 1 month. And in fact, I reported this in a journal, Oncology, back in September '02, reported responses of prostate cancer, of men with prostate cancer to thalidomide. One of the other anti-angiogenic agents we use is anticoagulation, particularly Lovenox, low molecular weight heparin. It has anti-angiogenic properties and a number of other properties. Now, the problem is it would be nice if cancer cells produced a single pro-angiogenic factor, only one thing to bring blood supply to it. But other than a rare type of cancer, they don't do that. They make many pro-angiogenic factors. But what's interesting is some of the pro-angiogenic factors, they can make anti-angiogenic and pro. They make a variety of both. But some tumors can make something that is pro-angiogenic in the primary site, but anti-angiogenic in the metastatic site. And this is why removing the primary can make metastases worse. And in fact, virtually all urologists and radiation therapists have found examples or have examples in their practice of patients whose PSAs rapidly increase following surgery or radiation therapy. And you see the same thing in diseases like osteogenic sarcoma, where you remove a leg, for example, and within 18 months metastases appear in the lungs. The leg's gone. The metastases were in the lungs. They didn't show up because the sarcoma in the leg was producing anti-angiogenic factors. And just to show you an example, this was a patient with a metastatic cancer, unknown primary. He had all types of different chemotherapy. And he had, this is a CT scan of his liver. He had a 3.3 centimeter metastasis in December '01. He was treated with anti-angiogenic cocktail. In May '02, it was smaller and smaller still in September '02. And he had this pelvic mass, 3 centimeters, December '01, smaller and stable. He had this huge pelvic mass. This is air in the rectum, this is bladder. None of this is supposed to be there, and it shrinks to 3.8 centimeters and 4 centimeters. And a separate pelvic mass, 3.7, 2.8, and stable 2.8. But this was a patient with metastatic with prostate cancer that recurred, a metastatic disease. His PSA was 80, started just on GM-CSF. His PSA dropped to unmeasurable levels and remained there over a year, and it was still ongoing at the time of this report. This is one of the drugs in our 9-drug cocktail. Celebrex, which is a COX-2 inhibitor, you see it on TV for arthritis or pain. It's anti-angiogenic. A report appeared in 2002. 13 patients had rising PSAs after radical or radiation therapy. They were treated with Celebrex. 38% had their PSAs go down, 24% stabilized, and 4 out of the remaining 5 had their PSAs doubling times, prolonged, an average 3-fold. COX-2 inhibitors also may help to prevent Alzheimer's disease. The low dose or metronomic Cytoxan chemotherapy I mentioned. I'll just point out that drug or chemotherapy can develop resistance to high dose chemotherapy given, for example, every 3 weeks, which has been standard. But the same medicine, the same chemotherapy given in pill form in mini dose daily can cause remissions. So the disease progresses on high dose, responds to low dose. Another part of the cocktail is interferon. Interferon is something that was going to be the miracle medicine for treating all kinds of cancers, the magic bullet. It does treat some cancers. I've been using it as an anti-angiogenic agent. It's a naturally occurring product. It has anti-angiogenic properties. And they also can directly kill some cells, some cancers like leukemia. Dr. Folkman has successfully used this to treat certain types of rare vascular malignancies. And interferon inhibits certain pro-angiogenic factors, vascular endothelial growth factor, some of these others. And intermittent treatment at maximally tolerated doses is not nearly as good as lower doses on a more frequent schedule. And in fact, low-dose interferon, the dose efficacy is optimal at low doses and declines at higher doses. Altogether, 120,000 people have been prescribed thalidomide for a variety of malignancies. There is no question that the age of anti-angiogenesis is upon us. Low-dose methotrexate is a form of chemotherapy. Again, oral, twice a day, just 2 days a week, anti-angiogenic. Zometa or Iridia, anti-angiogenic. Rosiglitazone is a diabetic medicine, also has anti-angiogenic properties. This was a report just appeared in the urology meetings in April, this past month here in Chicago. They treated 14 patients with interleukin-2. This is something I've just started to add to my cocktail for men whose PSAs have started going up in spite of the other parts of the cocktail. And they reported one man who had a complete remission from 2 to 4 cycles of interleukin. They used high-dose intravenous. I used small-dose frequent. And his PSA became 0, and 14 months later it was still 0. He had a rising PSA after a radical. So it's proof of concept. Interleukin does have activity in prostate cancer. Some quick examples of responses to the anti-angiogenic cocktail. Within 2 weeks, it dropped 50% in this man, hormone refractory. Just a sidestep, if you're on Iridia or Zometa, metastatic prostate cancer, at times the bone scan will look worse, but the disease isn't progressing. Bone scans are abnormal when there's healing. And it's a false positive. Don't allow you to be deceived into believing you have progressive disease just because a bone scan may look a little worse or a little brighter. And in fact, they did bone scans and then autopsies on some men, and what they found that in a number of patients, the bone scan revealed many more metastases, and they just weren't there at autopsy. The overall correlation between finding cancer at autopsy and an abnormal bone scan, if you've never had Iridia or Zometa, was 85%, but only 35% if you're on Iridia or Zometa. So they're false positives. Dr. Judah Folkman of Harvard, I had the pleasure of working with him for 1 month in my fellowship. He's the father of angiogenesis. He's that rare type of discoverer that my prior slide describes about seeing what everyone has seen and understanding or gaining the insight to what no one could see. And perhaps soon his work will be given the credit that he deserves, and he'll be given the Nobel Prize in Medicine. That's my prediction. Our last topic will be triple blockade. If you want to take 2 minutes to stretch, you can. They've looked at 3,439 men who, with prostate cancer since 1989. And they followed them and found out what type of treatment they've used as their primary treatment. In other words, their initial treatment. And whether it's radical prostatectomy, radiation therapy, radioactive seeds. But one of the categories was, or is, PADT, primary androgen deprivation therapy. In other words, how many guys choose hormone blockade as their only initial treatment for prostate cancer? And I'm the one who pioneered triple hormone blockade with proscar maintenance, and literally I was ridiculed and scorned, shunned, and thought to be literally dangerous. But it's been interesting that in the last 10 years, the percentage of men who choose hormone blockade as their only treatment has risen from 4.6 to 14%, and that's in men who have low-risk disease, PSAs under 10, Gleason 6 or less, and who don't have locally advanced disease. These are the guys who are always pressured by their urologists and radiation therapists to have surgery or radiation or seeds. But it's more than tripled in the last 10 years. And for intermediate risk disease, it's gone up to 20%, and high risk, almost 50%. So more people are seeing that prostate cancer is a systemic disease. Systemic means it's outside the prostate when it's diagnosed. Now, the cure rates for breast cancer never went up, no matter how much you did radically to the breast. The cure rates went up when you added systemic therapy, hormone blockade and/or chemotherapy. And in fact, at this Harvard symposium yesterday, Dr. Kantoff agreed and volunteered that the improvement in survival in the future for prostate cancer patients will be from systemic therapy, not from any type of local treatment. That's kind of exciting for me. And one of the papers I wrote a number of years ago, I attacked the gold standard for treating prostate cancer, gold standard being radical prostatectomy. So I called triple hormone blockade the platinum and diamond standard. And there's a medical oncologist, Charles Snuffy Myers, who's in Virginia. He writes Prostate Forum. And he wrote earlier this year, radical prostatectomy no longer looks like a very golden standard. And the benefit of surgery alone now appears to be so limited that it seems possible radiation therapy or hormone blockade may provide superior results. I had one other really exciting thing happen to me last week. I got a phone call from Dr. Paul Lang. Paul Lang is the head of urology in Seattle. And he's a guy in his 50s. He had prostate cancer not that many years ago and had a radical prostatectomy. I've never met him. And he calls me and he said, I heard that you're treating some men who have prostate cancer with testosterone. I didn't know if he was saying he's taking away my medical license after that. I said, yeah. And he said, he's been asked to write an editorial on the role of testosterone in prostate cancer, and he wanted to know my experience. So I told him about some of the results, and he said, I knew it. I thought that testosterone might help some men with prostate cancer. And he's asked for me to send him a copy of the slides. So that was that's just incredible to have all this happen in the past week. So androgen deprivation for, quote, clinically localized prostate cancer, and I believe in 2/3 or 3/4 of the men, it's already outside the prostate when it's diagnosed. There are occult metastases in the bones, for example, but remember, we just talked about anti-angiogenesis, and maybe they're being inhibited by factors made in the prostate. But triple blockade, employing what I came up with, Lupron or Zoladex, either flutamide or Casodex, and Proscar, 5-alpha reductase inhibitor, was actually referenced. This is the article I wrote. And at this year's urology meetings, Dr. Eric Small in the syllabus referenced my paper and my work and said, you know what, the addition of Proscar might offer additional benefit over just combined blockade, especially or particularly in the context of intermittent treatment protocols. Now, Eric Small has fought me tooth and nail. We have some patients in common. He refuses to prescribe Proscar. In fact, one of the slides I showed you earlier, Steve W. with the PSA 95, and he's on cocktail and testosterone, he's one of them who he refused to prescribe Proscar to. And when he treated him the first time with hormone blockade, he didn't use Proscar. And a second cycle of hormone blockade, Steve had to force him for the Proscar, to get the Proscar prescription. So my protocol refers to the triple blockade, but it requires the use of 3 Casodex a day, not 1. And it requires the use of Proscar. I had someone in Boston yesterday try to tell me that saw palmetto and Pygeum africanum is better than Proscar, and it's, quote, reported that way in European journals. It isn't. It's not the same thing. It doesn't work against prostate cancer. Proscar does. And if you've previously been treated with either any form of local treatment or previously had hormone blockade, You might get 3-drug hormone blockade, but it isn't triple hormone blockade / Liebowitz protocol. You don't get the same percent response, or you don't get the same sustained benefit. If you've already had hormone blockade or local treatment, PSAs do usually become unmeasurable when you're on 3-drug hormone blockade. But when you stop and testosterone's recover 6 to 24 months later, PSAs almost always go up again. On occasion, I have had some men with sustained PSA responses, but these guys are the exception, not the rule. One of the most important messages I'm going to tell you tonight is if you've had a cycle of hormone blockade and now you're following your PSAs and your PSA reaches blank, and you say, or your doctor says, okay, you need to start another cycle of hormone blockade. Don't listen. Don't use an arbitrary PSA number to force you back on a second cycle of hormone blockade. And this was an abstract that I had published last year. Remember this message. The longer you are off hormone blockade, the much longer you will live. You can't get hormone resistant or hormone refractory unless someone puts you back on hormone blockade. The definition of hormone resistant or hormone refractory prostate cancer is a rising PSA when you're on Lupron or Zoladex. That means with a castrate level of testosterone. If you have a rising PSA with a normal testosterone, you're not hormone resistant or hormone refractory. And there are other authors who have used hormone blockade as primary treatment, not just me. This is a Japanese study that was just published this year. And between February 93 and March 95, they have 151 patients that they treated. Later, I'm going to show you my results with 171 patients. And you'd say, gosh, these guys have almost as many, and that was well in 93 to 95. It took 100 institutions in Japan to get 151 patients for this study. All mine have come out of my office. So in this study, men were randomized to either monotherapy, like Lupron, or Lupron plus flutamide. Casodex didn't exist then. And they were treated for 2 years. That's all the treatment they had. No local therapy, no more hormone blockade. And all of these men were either deemed poor risk for surgery or refused surgery, the smart ones. Average follow-up now 6.5 years. Over 40% were locally advanced. More than 50% or 59% had moderate or poorly differentiated prostate cancer. Turns out combined blockade is 68% progression-free survival, no evidence of progressive disease, much better than monotherapy, much better than Lupron. And of course I used triple, not double, and the double they used actually wasn't flutamide, it was another product that is not nearly as good as 3 Casodex a day. But overall, the most important statistic that urologists or radiation therapists quote is disease-specific survival. They say, even though I didn't cure you with surgery or with radiation therapy, there's a blank % chance that after 5 years you will either be alive or you will have died of something other than prostate cancer. They therefore feel they've helped you. Well, with just the 2 years of treatment in Japan, they had an 89% disease-specific survival after 6.5 years. 89% chance you didn't die from prostate cancer. And it turns out that that overall survival was no different from the general population without prostate cancer. No surgery, no radiation, and they didn't die any faster than the general population without prostate cancer. And they were spared the indignities of incontinence and impotence and the indignity of somewhere between 3 and 7% of men get after surgery of fecal incontinence, or that some 10 to 15% of men after radiation therapy have, quote, soiling. Another author in 2001 reported intermittent blockade, reported on a study rather where they gave either continuous, CAB, continuous, combined androgen blockade, or monotherapy. This was an intermittent study, so they either were on double blockade or single blockade. They were treated for 6 to 9 months with hormone blockade. When the PSA reached less than 4, they stopped. And they've had an average follow-up of 2.5 years. The only men we're going to be looking at are the 34 who refused local treatment. These other men had already failed local treatment. But this would be similar to the patients I've treated. And the next cycle started when the PSA reached 50% of the prior level, the pretreatment level, or it was over 10, or the patient insisted. And there's evidence to suggest that prolonged hormone blockade, not evidence, it's 100%. Prolonged blockade activates cellular and molecular pathways that cause prostate cancer cells to progress from hormone dependent to hormone independent. So when you're on continuous blockade, you essentially always get hormone resistant. Now, the cell cycle length from the start of one treatment, in other words, we're starting you on hormone blockade now. This is you're getting 6 to 9 months of blockade. Now you're off treatment until your PSA reaches 10 or half of what it was, or you want to go back on treatment. That's the off cycle. The average cycle length, 13 months. Average time off, 43%. Testosterone tended to recover within 3 or 4 months. But as the number of cycles increased, as the number of times that you retreated increased, the percentage of time off decreased. What can you say about that? You're causing hormone-resistant prostate cancer with intermittent blockade. And it decreased almost linearly with each cycle of treatment. However, in a study comparing hormone blockade as primary treatment, this was reported also this year, only 2 of 72 patients on an intermittent blockade schedule developed metastases. 93% were free of metastases at 5 years. The longest follow-up was more than 15 years. No surgery, no radiation. Only 2 out of 72 got METs. So that's 3 different studies I've shown to you. And here's a new one for you, I believe. The worst way to treat prostate cancer with hormone blockade is continuous. Definitely better than continuous, in my opinion, is intermittent. But intermittent is not the best way to treat. The best way to treat is with 1 cycle of hormone blockade and then figure out ways to never go back on hormone blockade. You can't get hormone resistant if you don't go back on treatment. And that is how I approach prostate cancer. Well, on the study I'm going to show you our results. I treated men for 13 months and 1 cycle, and then they're off treatment. And let's pretend 5-year follow-up. It means that on for 13 months, off for 47 months. If you look at the medical literature, all of these other authors, Strum down here, their average off-treatment cycle averages 8. Strum's was 15. It was a 12. This guy was 24, only had 13 patients with localized disease. So far, I'll show you some guys. For the group with 5-year follow-up, my guys are off treatment 80% of the time. The average with everyone else is in the 40% or much less. And each cycle, they're off treatment for a shorter period of time. They're getting hormone resistant. So what should you do to prolong or eliminate the need to go back on hormone blockade? You should be patient, not panic, with 1 PSA result. You know that there are other things that raise PSAs besides cancer. Benign prostate enlargement, prostatitis. I've also found that an infection anywhere in the body can raise the PSA. It's never been written about. I don't understand it, but I've just seen it. One notable example was a guy with a pocket of pus in his knee. The pus got drained, his PSA dropped by like 30% in a week. I can't explain it, but it did. And I've seen it with pneumonia. PSAs go up when someone has pneumonia, you treat them, it comes down.
Bad teeth?
I don't know about bad teeth yet. So you also, besides the 13 months triple blockade, don't shortchange yourself with 8 months or 9 months or 10 months. You need proscar maintenance. I'll talk in a little bit about Avodart, which is a new 5-alpha reductase inhibitor. I believe you should be on Celebrex or a similar COX-2 inhibitor. I believe in using some calcitriol, which is the active form of vitamin D, and I believe that you should be on Iridia or Zometa. I would caution you, if you take Zometa and calcitriol and Celebrex, you got to watch kidney function real carefully. They all three can affect kidney function. The thing that works the best to lower PSAs in men who've had 1 cycle of hormone blockade is taking 1 thalidomide a night. Now, thalidomide is the drug that caused those birth defects, terrible birth defects, the little flapper limbs that pregnant women, that babies born from women who had used thalidomide in pregnancy from the 50s or 60s. Thalidomide is a fascinating drug. It was sold over the counter in Europe and Canada. It was never FDA approved in the United States. And as little as 1 thalidomide in the first trimester could result in a thalidomide baby. And the reason that they had these short limbs is because thalidomide is anti-angiogenic. It turned off the blood supply to the limbs. And it is my most effective agent for lowering PSAs. And it always works within 1 month. And it works more than 90% of the time. The National Cancer Institute has done a study with thalidomide, and they found the same success rate. They use a higher dose than I do. What are the other things? If a guy's had triple blockade and he's off treatment and his PSA is going up, and I don't think it's going up, I think it's going up too fast. I don't, it's like, wait a minute, something's wrong. And I say to the guys, what are you taking? And I tell them, stop it, and let's repeat your PSA in 2 weeks. This is a list of the products that I found raises PSA. Soy products that everyone tells you to take. Modified citrus pectin, flaxseed, fish oils other than in fresh fish, MSN, MGN, NGM, phytoestrogens, IP6. They stop, PSAs go down. Now, what do most of these products have in common? They lower testosterone levels. Isn't that interesting? Now, I always came out against zinc, not because of experience, but because in AIDS patients, supplemental zinc shortens survival. AIDS patients' immune systems are much more impaired than someone with prostate cancer. But I now am neutral on it. I'm neither for it nor against it. But it's a major change in position for me. If you're forced to go back on hormone blockade, you must make it your last exposure to hormone blockade. Because every time you go back on hormone blockade, you're playing Russian roulette. You got to spin the cylinder, put the gun to your head, and say, okay, I hope that this cycle of hormone blockade is not going to cause hormone refractory prostate cancer. And you pull the trigger, because you go back on treatment. So I only want you to do that 1 time. And how can you then make it your last cycle of hormone blockade? You have to add chemotherapy. And you also, this will come as a surprise to most of you, never reuse flutamide or Casodex or nilutamide. Never take a second cycle of Casodex or flutamide or nilutamide. And I wrote about this and named this the Benedict-Arnold syndrome. And for those who haven't heard of it before, in the French-Indian War, Benedict Arnold was a great general. He won many battles for us, United States. However, in the Revolutionary War, he became a traitor, and he hurt us. Casodex and flutamide, nilutamide are Benedict Arnolds. A simplistic way of looking at it is prostate cancer cells are like a lock. They have an androgen receptor on them. And flutamide or Casodex is the key. and it reaches into the lock, it turns the lock to the right, prostate cancer cell dies. Good. Over time, that androgen receptor undergoes a mutation. And now, when casadextroflutamide goes into the lock, it turns it to the left, and it stimulates prostate cancer cells to grow. And unfortunately, you can't see it doing that because you're on Lupron, and Lupron's bringing your PSA down. So you think it's the combination. But casadextroflutamide may be driving it up. So if you're going to go on another cycle of hormone blockade, always use an adrenolitical agent, ketoconazole or aminoglutathione, not antiandrogens. Adrenolitics, these two medicines, don't affect the receptor. They work by stopping the adrenal gland from making male hormone. Casodex and flutamide don't stop the adrenal gland from making male hormone, they block the receptor. So I recommend adding in 15 doses of weekly low-dose chemotherapy. Doesn't cause nausea, doesn't cause vomiting in the schedule I give, almost never causes hair loss. I also recommend adding 1 thalidomide a night. You have to take anticoagulation, and I only use 9 months of hormone blockade the second time. And then depending if you had a low testosterone going in, I might consider high-dose testosterone. For patients who present with high-risk features on presentation, PSAs over 20, Gleason scores 8 or higher, locally advanced disease. I give them 12 doses of weekly low-dose chemotherapy, 3 weeks on, 1 week off, and 13 months triple blockade / Leibowitz protocol. Proscar has been shown to inhibit the growth of prostate cancer cells in vitro and in animal studies. That's been shown. It's also been shown to help men with prostate cancer. The way that Proscar works is in order to convert testosterone to dihydrotestosterone, you need an enzyme 5-alpha reductase. Proscar blocks that enzyme. So when you're on Proscar maintenance, you get low levels of dihydrotestosterone in the blood. The brain senses low levels, and it tells the body, make more testosterone. So on Proscar, you have a higher testosterone than you had before you were treated. And I've shown before, I think high testosterones are a good thing. Now, there are actually 2 different types of 5-alpha reductase, type 1 and type 2. Proscar only blocks type 2. Type 2 is found in the prostate, type 1 is found in skin, liver, and some of it in the prostate. So GlaxoSmithKline drug company comes out with Avodart, dutasteride, Dua, like 2, blocking the 5-alpha reductase, or finasteride. It blocks 1 and 2. Proscar only blocks 2. They both seem to lower PSAs by 50% in men with benign disease. Proscar lowers dihydrotestosterone levels by 70 or 75%. Avodart by 90%. So naturally, you would think, as I concluded, I ought to try giving some men with prostate cancer Avodart. They both raise testosterone levels, and maybe Avodart raises it a little more. So I was even more interested in Avodart. So I had about 50 men beginning in January or February this year, all of whom were on Proscar, different stages of prostate cancer. They came to the office. I got GlaxoSmithKline to give me samples, and I put them all, 50 men or so, on Avodart. And 1 month later, baseline I checked PSA, testosterone, dihydrotestosterone levels. A month later, repeated. What I found is that DHT went down more on Avodart, as predicted. When they changed from Proscar to Avodart, a few PSAs went down, but more of them went up. When they switched back to Proscar, a few PSAs dropped back down. And separate from that, if you're on high-dose testosterone, 1 Proscar alone doesn't lower your DHT enough. You either need Avodart or 2 Proscar. But I was stuck with more PSAs went up on Avodart than down. So my conclusion as of tonight is, with 70% confidence, I say Proscar is better for prostate cancer than Avodart. Obviously, that means this is a work in progress. My final recommendation is still evolving. Okay, triple blockade. 171 men, all in one practice, all biopsy-confirmed prostate cancer. All men wisely refused local therapy. But it was interesting, I was asked to speak at this AUA meeting, and Peter Carroll, urologist from San Francisco, said Dr. Leibowitz has a very interesting practice. Men who want hormone blockade seek him out. Maybe that's why they're doing better. Maybe it's not the hormone blockade. Maybe it's that kind of guy seeks me out. This was the average age, 66. We had 4 guys in their 40s. Did not want to have impotence and incontinence the rest of their lives. The baseline PSA, 11.6. I don't know how many of you are familiar with Patrick Walsh at Johns Hopkins, best known urologist in the country. He won't operate if your PSA is over 10 because you get a very poor cure rate with local treatment. Well, we had 27 men with PSAs over 20. Their PSAs averaged almost 32. And we had 36, so we had altogether 63 men with PSAs over 10. And looking at Gleason scores, our average was 6.6. Walsh won't operate above 6. We had 69 sevens. We had 12 eights, so that's 81, 87, 89 out of 171 he would consider too advanced for surgery. So our series is tipped towards negative prognostic factors. Our clinical stages was as usual, expected with other series. Let's look at the follow-up for the first 130 men. Follow-up is now over 5 years. They started with a PSA 11.4, current PSA 2.6. Let's look at the first 81 men. Average follow-up 6 years, their PSA 2.56. That's pretty close to 2.59. Let's look at the first 41 men with an average follow-up over 7 years. Their average PSA 2.4. Longest follow-up, 140 months, just under 12 years. Testosterone before treatment, 381, on Proscar, 420. That figure that urologists and radiation therapists like to say, the chances you'll be alive or have died of something other than prostate cancer when you're treated with triple blockade as your primary treatment, at 5 years, 99.4%. We had 1 prostate cancer death in the series. And this was a guy with a very rare type of prostate cancer called endometrioid. We've had 12 men who have required a second cycle of hormone blockade. 12 out of 155 who finished treatment. And if you look at these 12 men and you try to figure out, because you learn more from your failures than your successes. And I never believed 13 months of triple blockade was going to be the magic answer for everyone with prostate cancer. That would be just impossible. And in fact, when I first started to use triple blockade instead of local treatment, my belief was that you'd get treated for 13 months, you'd go off treatment, and 2 or 3 or 4 years later, you'd go back on treatment. I never could believe that there would be some guy who'd be off treatment now almost 10 years. That just didn't make sense to me. So the high-risk features, high risk, remember, Gleason 8 or higher, PSA 20 or higher, locally advanced. This color is the high-risk features. Being red-green colorblind, I'm not sure if that's pink or red or what color it is. The one guy who died had a Gleason 8, but it was endometrioid. And endometrioid means it looks like uterus rather than prostate. It doesn't arise in the prostate glands. It arises in the cells that line the ducts that drain the prostate. But notice these guys who needed a second cycle. PSA almost 60, 36, 51, 23, Gleason 10, Gleason 9, 9, 8s, locally advanced disease. And we had more than 50 men with high-risk features. We've only had to retreat 12. This is about endometrioid. If you have a radical for endometrioid, you'll find 93% of men have disease outside the prostate. Almost half with seminal vesicle involvement, which is virtually always systemic, and a quarter with lymph nodes, and another half, or close to half, with positive margins. This is one of my favorite slides. And you're only the second audience ever to see it. This is where men start triple blockade. This is their baseline PSA. And each line is one patient. And each of these diamonds is one PSA. So in general, what the pattern I think you see is on treatment PSAs go down to unmeasurable, which they did in everyone, and then rise and in general flatten out. And here's a guy with 10-year follow-up. That's what you see in general. Now these guys with the marked decline suddenly are men who were retreated. This guy particularly is interesting. He was a Gleason 10, and he went 6 years before he needed another cycle of hormone blockade. 6 years. And his original PSA was 18. Well, what about low-risk features? What about if you start out with a PSA less than 4? This is one patient who's out about 9 years, and his PSA is essentially still unmeasurable. He started with a PSA less than 4. And their average PSA is 0.75 with a 4-year follow-up. And you could break it down into other high-risk factors. These are guys with PSAs under 10 to begin with. This guy was obviously retreated. This gentleman stopped his Proscar. And this guy's kind of interesting. He started with a PSA between 5 and 6. He's been off therapy since September '94. And his PSA is still 5 or 6, not quite 10 years from the time he was treated. This was PSAs greater than 10, less than 20. That's pretty nice. And PSAs that says less than 20, but it's over 20. And how exciting is this? PSA over 20 to begin with, and it's about 2 now. This is the first patient that I treated. He had a PSA of 34, elevated prostate acid phosphatase, which means it's D0 disease. He was treated in September '91. At that time, I treated for 2 years. I began treating for 13 months in '93. And since September of '93, he's just been on Proscar. He's never had thalidomide or chemotherapy or any of that other stuff. And off treatment since September '93. In January '02, the visit after this, when he came in, he said, by the way, what was my PSA last visit? I said 3.94. He said, oh, I guess that hormone blockade only works for a while and then it wears off, huh? I said, Max, you've gone since September '91. This is January '02. And your PSA used to be 34. It's under 4. You have a prostate gland. PSAs go up as you age. You know, give me a break. Which he didn't want to do. But that's what happened to his PSA after that. The next one. And rats. It'll show up on this if we look at it, but his current PSA is about 3.2. This was another guy, PSA 29 and 27, Gleason 4 plus 3, triple blockade, ends in January '99. So that's 3.5 years later, 1.67. No other treatment than Proscar. This is a gentleman who I treated in '95, PSA 15. He stopped therapy in August '98. I didn't see him from August '98. In August '99, he calls panicked on the telephone. His PSA is 9.89. I said, oh, did you stop your Proscar? He said, yeah, I'm on saw palmetto. I said, okay, stop your saw palmetto, go on Proscar, and let's see what happens. And this is what happened. Well, in October '01, he had a kidney stone. And his PSA shot up, and His urologist, in removing the stone, nicked the ureter, and he had to have a Foley catheter through this period of time. And they took the Foley catheter out in May '02, and look at his nice PSA. Nothing but proscar. That's sweet. PSA 15 in July '97. He's almost 6 years. It's 2.5. I've got some others to show you that I want to do on this overhead projector. There's 2 points that I think are critical to make, not just more of the successes. And while we're doing that, I want to read a letter I got the day before I left for these lectures. This is a gentleman who lives in Knoxville, Tennessee. And he wrote to his urologist in May 2001. As you know, I was diagnosed with prostate cancer 10 years ago, PSA 31, Gleason 7. Had a radical. It spread to my lymph glands. You treated me with Lupron for 5 years. You already told me that after about 5 years, my PSA would rise, and then I would die 2 years later. Nice. I elected to have orchiectomy to remove testosterone as much as possible. In June of '92, we added flutamide and Proscar. Then changed it to Casodex in '98, and my PSA has remained less than 1 since June '92. This is May 2001 when you wrote this. Testosterones have been run every 6 months, and of course it's castrate. I stopped Proscar December 2000. I would have the orchiectomy reversed if I could. That's difficult to do. You've allowed me a great deal of freedom of choice for my treatment, and I've appreciated this very much. He's read some of my work in PACT, and he said that 5 years ago I agreed with the majority of public speakers that the procedure promoted by Dr. Leibowitz was too far out to be taken seriously and in fact dangerous. The idea of encouraging testosterone to return appeared like throwing gasoline on a smoldering fire. It now appears that intermittent hormone blockade is widely accepted. And he then goes on with some of that, and with that letter, he sent a letter to me, May 12, 2003. Thanks to you, my quality of life is much better than I ever expected it to be. He had pointed out that although his PSA was less than 0.1, he could no longer, for the last 3 or 4 years, play even doubles tennis with old ladies because of fatigue, no energy, poor concentration, poor coordination, and pronounced muscle atrophy. I had no desire to do anything but sleep. I became severely depressed and was placed on Prozac. I've been advised never stop Prozac. To get exercise, I would walk when playing golf. Became so tired it was difficult to make it past a few holes. I require a nap every day for the past 3 years, no matter how inconvenient for family or friends. I used to play golf in the low 80s 6 years ago, and now it's over 100. My friends I used to beat by 12 strokes are now beating me by nearly as many. Some of them are over 80. He requested that he go on testosterone. So he wrote to me, my quality of life is much better than I ever expected to achieve 2 years ago. And then he enclosed a copy of his history. His urologist promptly wrote back he did not think testosterone was a good idea, but if I wanted to do it, he would prescribe it. And he gave him a prescription for Androgel, which is a testosterone lotion that you rub on. That's my favorite preparation. He said, my golf game is still bad, but I can now walk 18 holes and hope for my improvement at age 75. Pretty good for a guy that was supposed to die more than 5 years ago. He's the only patient that this urologist will give testosterone, although I believe he secretly is pleased to be part of it. Dr. Leibowitz, except for your trailblazing work, I hate to think how bad my quality of life would be today. It appears you're finally being acknowledged for the great work you've done in prostate cancer treatment. I'm truly grateful. If you ever want more details or follow-up, please let me know. So we're going to talk now about when to go back on hormone blockade. And what we notice is a guy with a PSA 21, got Lupron alone for 1 month, saw me, I gave him triple blockade through August 99. He goes off treatment, PSA 6.21. And I think you've been told by every prostate expert, if your PSA is over 5 on Proscar, actually on Proscar maintenance, they say over 2.5. But definitely over 5, go back on hormone blockade. And I said, gosh, you don't feel bad, let's just see what happens. Next one. So his PSA that was 6.21 on no treatment other than his continued Proscar. This is May 03, PSA 4. This is his own testosterone. He's never had Iridia. He's on Celebrex is the only other thing. Celebrex and Proscar. So if he had been retreated with hormone blockade there, and he'd still be alive and with a controlled PSA now, we'd be saying, boy, look at how good we did with that second cycle of hormone blockade. Okay, next. This is one of the 2 or 3 most nervous men I've ever met in my life, as an anxious. He had a Gleason 6 in 98, PSA 14, but he was already on Proscar. So his real PSA was 28.5. Triple blockade, and he goes off treatment in May 99, and then his PSA a year later goes up to 6.5. Look at this doubling time. In 6 months, it went up, what is that, 600%? More than 600%? So I said, let's just see how you do. It was 6.51. Yeah. Then he got up to 7.6. Then he came down. Now he's going right back up, April 02. So let's continue to watch. And now we're in big trouble. Now he's up to 11.9. And this guy was so nervous and anxious that on this day, I had to tell him, when he asked for his PSA, there was a lab error, your tube of blood got broken. I don't know the result. Let's wait a few weeks and repeat it. This is true. But he's, you know, it just didn't make sense to me. He had a nice high percentage free. Next. And I don't think anyone would guess and know what treatment I gave him there that made it come down. It might be, what did you tell me you were taking? MV, what was it?
Uresa.
No. You didn't, MVI or something? So that brought
MVP or something.
MVP, okay? So if I put this guy on MVP, we'd all be saying this is a great response. I put him on nothing. He's still been on Proscar and Celebrex, and he gets some Iridia every 3 months for osteopenia. No other treatment. So don't panic over any one PSA, okay? The last guy.
David?
Yep. This is the most interesting of all of them I'm going to show you. This is a guy that in 93 has a PSA in the 20s, and it's repeated, it's in the 20s, and he goes to UCLA, and you've heard of guys who have biopsies and they don't show prostate cancer. This guy had 3 sets of biopsies and they didn't show prostate cancer. He went to Dr. Strum, and Dr. Strum started him on hormone blockade in January 97, and in August he asked if he could switch to me. He had seen me in 96 and wanted me to treat him for prostate cancer. I said, I don't treat for prostate cancer without a biopsy that shows prostate cancer, because I don't know that you have it. But he was already on hormone blockade. I told him I'd finish his 13 months and we'd follow him. So he went off, he was treated with triple blockade. He ended it in February 98. PSA 15. How many would recommend putting them back on hormone blockade? PSA 15. And it's gone straight up. Nobody would retreat this guy?
None,
1.
none now.
Okay, well, let's see what happens. Now his PSA is 21.6. He's on Proscar, you got to double it, it's 42. His PSA is twice as high as it was before he had hormone blockade. How many people believe he has prostate cancer? Okay, not very many believe he has prostate cancer. A 42 PSA. Well, I didn't believe that he had prostate cancer. I did nothing. Kept him on his Proscar and his Celebrex. He's on Zometa every few months because he has osteoporosis. Okay? There was that 21, and now he's averaging in the teens. And now we're up to November 01. But it doesn't look like prostate cancer when it does this. So I said, let's just watch. Okay? Now his PSA is in single digits. And I did nothing different. Now how many believe he has prostate cancer now? Nobody. And neither do I. But it shows you how little we know about prostate cancer. And you just can't believe that a PSA elevation is always due to prostate cancer. That's it on that.
Why do the AMS test, AMS?
Because I think it's a worthless test. As always, be happy, be well, live long and prosper.
We're new, so if this sounds stupid, I'm sorry.
There's no question that's stupid.
If you do hormone blockade therapy to block the production of testosterone,
Yes?
then why would,
That was a good question. Why would later I say you do well with testosterone?
Yes.
It's because when you have prostate cancer to begin with, it's untreated, you have a large bulk of it. You debulk it successfully with triple blockade, now there's hopefully nothing but very little left. Then I believe testosterone is beneficial. But I'm not saying it's okay. I'm telling you why I think that it's okay in some men, but you can't go out and treat yourself.
I have two questions pertaining to testosterone supplementation. The first one is, do you always have the anti-angiogenic cocktail?
No, only in men that are hormone refractory.
And the second question is there any evidence that you can do testosterone supplementation on an intermittent basis, just as we do hormonal blockade?
You're going to then, just like on men on intermittent blockade, you're going to cause hormone-resistant prostate cancer.
So you stay, once you get on this, you stay on it indefinitely.
And not only that, what I found after treating 100 guys is the only ones who do well are those in whom you get the testosterone levels quickly to over 1,000 and they stay there. If you try to build up slowly, you get hormone resistance. Remember, low levels of testosterone stimulate prostate cancer to grow. In that LNCAP model, high levels inhibit it.
Would you comment on the effects on libido of the various treatments you've talked about?
Sure. When you're on hormone blockade and your testosterone level drops to castrate levels, you get loss of libido and impotence. I've had about less than 10 men who remain sexually active on hormone blockade. But you stop after 13 months, your testosterone begins to recover within a few months and reaches pre-treatment levels in most men by 6 months. And in general, you go back to baseline. I've developed a questionnaire that I'll ask men when I'm first going to start them on hormone blockade. If on a scale of 1 to 10, if 10 was the most libido, desire for sex, you had in your life, like when you were a teenager and wanted it all the time, what was your libido like just prior to your biopsy, the month before you knew you had prostate cancer? And most men would tell me it's 4, 5, 6, maybe 7. I had 2 liars who told me it's 10. And then I'd ask the same question for potency, ability to get and maintain an erection. I know that when we were teenagers and we used to hang things from it, washcloths, some towels I heard from some guys. And again, 2 guys told me it's 10s and most guys are between 3 and 6. After hormone blockade, the worst that I see is 1 notch lower. But again, as you age, libido and potency go down.
We dislike the use of soy products. What about dairy products?
No problem. I only dislike things that lower testosterones. And the MSN, MGN, all that stuff, you have no idea what's really in them. These are over-the-counter products. They're not FDA regulated. They may say what's in it, but a lot of them even say it's a proprietary blend. And some of them, guys come in with these things, and some of them have bovine orchis in them. Bovine orchis is cow testicles. And they wonder why there's an effect on their PSA.
So in other words, you would use regular cheese instead of soy cheese or soy
Yes.
milk or regular?
Yes.
Okay, thank you.
I have a Gleason score of 6 and PSA of 2, and I was diagnosed a year ago. I'm doing watchful waiting, but after hearing about Proscar, do you think I should go on Proscar?
No, Proscar alone is not a good treatment for prostate cancer. There's too much bulk disease. And I would have your Gleason score rechecked at a tertiary center like Johns Hopkins or David Bostwick, because usually high Gleason scores have low PSAs, Gleason 8 or higher, and a low PSA, high Gleason score is a much worse prognosis than a higher PSA with the same Gleason score.
Do you treat a lot of patients from outside your area, and if so, how does that work?
The answer is yes, and if somebody wants just to get an opinion and a treatment plan, they come to see us. If they want us to supervise their care, if they're on hormone blockade, they see us every 3 months. If they're on chemotherapy, they get 1 dose from us, the next 2 doses here in town, 1 week off, and then start over again.
Thanks.
I had radiation treatment. I also have polyneuropathy, so my immune system is compromised. Currently, my PSA is 0.4, but my testosterone level is like 156.
Yeah. By the way, radiation does that.
I'm depressed, et cetera, et cetera, et cetera. Can I take testosterone?
You'd have to get a consultation. We'd have to know your original PSA, your Gleason score, and there's obviously a risk in doing that, but I have treated men in that situation.
You spoke against phytoestrogens,
Yes.
and how do you, what's your opinion about PC-SPES?
Oh, if you have metastatic hormone refractory prostate cancer, PC-SPES is a great drug. It's outlawed, and any of the other companies that are making so-called copy drugs is horrible stuff, and I think that it's foolish to use. But there's been some legislative work in California where it looks like Sophie Chen is going to be allowed to make more PC-SPES that can be prescribed by physicians, not over the counter.
Okay. My husband had
This is deja vu.
out 3 months ago.
Huh?
And the pathology report I read said he's got positive carcinoma cells in the vas deferens and seminal vesicles. What does that mean? Does that mean he still has the cancer, or?
No, the presence of cancer cells in the seminal vesicles is somewhere between 70 and 90% likely that there's cancer cells that left the prostate and are probably in the bones already. So it's a systemic disease. And I would not allow them to do any other local treatment, and you'd have to seriously consider either hormone blockade or hormone blockade plus chemotherapy. If your husband is as young as you look, I would do the addition. Yeah, I would do both, because you want him to have a normal lifespan. You want to do everything to try to achieve that.
Happy birthday.
Happy birthday.
We know that raising testosterone levels doesn't work for everyone. What is the percentage of successful records of a significant number of people so that we can get a balance of what's good and what's bad?
In what stage?
Well, when you're on a period of getting
But I'm saying, is it somebody who's...
a person who's been recommended to go on increasing testosterone. That's what
Are they hormone refractory? Are they metastatic? Have they had prior hormone blockade?
hormone refractory. They're not.
Have they had any form of local treatment?
They had a radical to begin with and a failed radiation.
Yeah, and if your PSA is rising, it's not a good time to go on testosterone. The ones that have the highest success rate, which is probably, I don't know, over 75%, is guys that have had just triple blockade, no local therapy, and like to have higher testosterones. I've never had to put any of those back on hormone blockade. I have had to stop testosterone in some of them, and PSAs promptly decline.
That was the percentage I was looking for. How many had to stop?
But I'm now talking about men who've never had local treatment. I'm not keeping these statistics in any particular order. I'm in private practice, and it takes a great deal of energy to do this in addition to private practice. But if anyone wants to come audit my charts, I would love it.
Doctor, what do you think about the vaccine or immunotherapy?
None of them have worked very well for men with recurrent or metastatic prostate cancer. There's hope for the future, but it's not good therapy just yet. Thank you all.
Well, let's have a round of applause.
Good luck with your husband.
Thank you. No, I'm sorry, we had his prostate out.